Thank you. I'm going to start off this presentation in a very unusual way. I need a male in the room to help me. I just discovered just before I walked up here that I left my cell phone in the male bathroom. So if someone could check it out, I would appreciate it. So I'm not ruminating about my cell phone getting lost. I've never done this before, but let's see if this works. Four goals of this talk today, this brief talk, is to provide an overview of what I see as our program of research, which is best conceptualized as a public health research strategy behind the family checkup. The second goal is to describe the variations in the evidence for the family checkup that apply to specific service settings. Summarize trials and tribulations of implementing the family checkup model. So we have been implementing in a variety of settings. We designed the intervention to implement in a variety of settings, and I can talk and compare and contrast issues regarding a variety of settings. And briefly summarize lessons learned. I want to say, though, that I do appreciate being invited to this panel, and as I look around the room, there's many of the people that I respect and are my heroes too, so it's kind of a pleasure to be involved in this meeting. Overall, this is what I see as a general public health strategy. It's an iterative process. The question keeps coming up whether or not we should be revising our interventions, and of course we're going to have to revise our interventions the more that we have contact. The more that we have contact with our clients, which are the communities, the more that they're going to shape us in terms of the kinds of interventions we will be developing. And I'll say a little more about that. But the general strategy of a translational process is we have a developmental and a measurement model. We use that to define an intervention experiment. We've just heard about a couple of very interesting intervention experiments. And then when we revise for public health service settings, that means we revise the, this is good luck. Thank you. Thank Dave for the helping out on this talk today. And then we revised our intervention for public health service settings with the idea that we're trying to design something that's going to actually be picked up. And then, of course, after we test and tailor for real-world conditions, we may end up circling back around and revise our developmental model. And I think this is true for our experience when we've worked in various communities and have looked at factors that are influencing families that weren't originally conceptualized in our model. For example, moving from into the American Indian community, we started to were hit over the head with the importance of historical trauma in our overall conceptualization of a developmental model for family interventions. Can't just walk in with an evidence-based practice. There's much more going on in the communities that need to be acknowledged. The general idea is, though, that as we go through this cycle, we keep improving effectiveness, efficiency, reducing expense, and I'd argue for improving the ethics of what we're doing. Is it ethical to provide services that are not supported or potentially iatrogenic? And we need to start dealing with those issues as ethical issues, not just evidence issues. So this is a brief example of this instantiated through my own program of research. Around 1987, we developed the Adolescent Transitions Program. We thought that was a pretty cool public health intervention model. The model that we were working with at the time was the PMTO model, which is a clinic-based parent training model. And we thought, well, why don't we start doing these groups, this intervention in groups, and we can increase the number of parents that come to the groups, we can offer them in schools, we can reach out, we can get them engaged. And another bright idea is why don't we start working with kids in groups and start helping them develop self-regulation and use the power of the peer group to change their, improve their self-regulation and reduce their drug use. Compelling. We found that the peer groups actually made kids worse, so we quickly dropped that component. And then for the parent groups, I realized at the same time I moved over to the university setting, very excited about the public health strategy, so right away I started running the ATP parent groups in our public schools around the Eugene community. And my first middle school, I recruited them in exactly the same way as I did in my randomized trials with lots of funding. Out of 50 parents identified, how many parents do you think showed up to our group after we went through all the steps? 5? Real 2. We probably could have got 5 had we tried harder. 2 parents, 4 therapists. So they were stuck. They had to stick with our group. So at that point, I started thinking about how can we develop an intervention. I love the parent groups. I ran parent groups. I think they're a really important part of our portfolio, but we also need other intervention strategies. And so from that, I developed the family checkup model. And now we've developed that for the schools, WIC, Women, Infants, and Children, Community Mental Health, and Pediatrics. So, and as we go along, I hope that's improving efficiency. Briefly, the family checkup model is a 2 to 3 session intervention. It involves an initial interview, an assessment, and then a motivational feedback session with parents. And the motivational feedback is using basically MI principles. It's not simply a reporting of the facts, it's really a motivational narrative. So we're using data to generate a narrative of change with the family. If you're to look at a session and say, is this a great session or not, it's not the therapist talking for the entire session giving feedback, it's actually the parent talking out loud about change. So evoking change talk is the key strategy for the feedback session. And now the idea really is to hook up parents to the right intervention or the right amount of intervention based on their need. So brief, tailored PMT, PMT treatment, which might be more focused on weekly sessions over a period of time, could involve some work with the child, CBT, or community treatment resources, for lack of a better term, wraparound, but basically families that are multiple trauma or need multiple resources, trying to hook them up with the right resources under the right conditions. For example, a young mom who's 6 months in recovery from methamphetamine with 3 small children and single, the best resource for her might be a relief nursery where they provide support for the kids, provide recovery support for her, as well as some parent training. It's unrealistic to think that a brief parent training model is going to be enough for this particular family. Again, this is a public health model, so we are thinking about a brief intervention service offered regardless of clinical status of the family. So some families are already doing quite well, most are, and some are not, and some require more intervention support. Conceptually, this is the parent training model in which I was trained in. Patty Chamberlain, Marion Forgatch, John Reed, and Jerry Patterson trained me in this particular approach. And the concept is that the family checkup works on this aspect, this general characteristic of parents to be motivated, proactive, and planful. And those that have some of the parenting skills that we love and care about, they are more likely to engage those parenting skills. And many parents do have strengths in one or more of these areas. And those that could benefit, we motivate them to engage in perhaps positive behavior support, or perhaps setting healthy limits, or perhaps family relationship building. Imagine a newly formed step-parent family. Both parents come into the situation with lots of skills, but they're navigating a new set of relationships, a set of working on family relationship building, come up with a good process for decision making, talking about roles is extremely helpful for a family going through that type of transition versus a parent who may have always been super positive and much like a friend to their child. Now their child's 13 in the fast lane, 13 going on 19, I like to say, and it's time for a parent to set limits, but they don't have a good skill set for that. So that's the model, that's the framework. So now can we implement this in contexts that affect large numbers of kids and families? And so to do that, you want to embed it into a service system, much like Kimberly and Doreen Koretz talked about in their original great paper on embedding services in taking evidence-based practices into services. So we start off with well, one approach was to work in WIC settings with parents. And this work was with Danny Shaw. Lauren was actually our original project coordinator, and it's been difficult to replace her even now she's been gone for 10 years. We're still pining her. So with Danny, we had 2 randomized trials, and these are basically, we had effects on the behavioral domain that last up to 5-6 years so far, and the affective domain, reducing children's early onset depression, and more importantly, maternal depression. And in the parenting domain, we've been able to improve parents' positive behavior support and reduce coercion. And the interesting thing about reducing coercion, this is a public health model, for example, 731 families. We were not able to reduce coercion unless the parent consultant gave videotape feedback on their parenting. Videotape feedback was a key to helping parents see their parenting. And without that many sessions, they were able to reduce their coercion. In cognitive educational outcomes, we're finding long-term effects on effortful control, language development, and school readiness. Now, when we model engagement in the intervention, basically the basic unit of engagement is the family checkup. We're still working on trying to identify number of sessions or key sessions, or we collect data on every minute of contact, and Lauren will testify. The therapist actually kept every minute of contact and what they contacted families. So far, we haven't been able to find a dose response to these types of effects, except for whether or not they engage in the feedback session. Not saying it's not out there, and if someone wants to play with our data and find it, there could be first author, who's public. The other service setting that we really started off in, and this was with my colleague Kate Cavanaugh and Beth Stormshack, is public schools. And up to middle school, I'd say a good percentage of all children go through public schools, and that's usually the field setting that they have the most trouble in. So 2 studies, we randomized kids. One had about 998 kids, and the other one is 600. Randomized them to a family resource room at the individual level with a family checkup versus a control. And again, we found long-term outcomes on behavioral outcomes, including antisocial behavior from age 11 to 19, intention to treat, early drug use, and recently we found effects on marijuana use, especially up to age 23 at the individual ITT level. But when you look at engagement, you get larger effects on marijuana and alcohol use. Problem behavior, high-risk sexual behavior. Emotion, we did get effects on depression. We got ITT effects on depression. We didn't target depression. It's a family checkup, so we're focusing on parenting. But the kids themselves, the high-risk kids, were less depressed over 3 years. We improved parent monitoring, reduced conflict in families, and then Beth Stormshack found that we improved parents' grades. We improved the kids' grades and attendance in high school. So lots of evidence that this is a potentially useful intervention. So then we basically modeling our work after Patty and Marion, the folks that are in Eugene, who I admire, and they're way ahead of me on this stuff, try to figure out what our implementation strategy would be. And so we came up with a 4-phase model, and I won't go into too many details. It's very relevant to what you see here. Probably the most important piece is this coach, this measure called the coach. Like Willie was talking about, unfortunately, we designed the family checkup so we thought it could be delivered by paraprofessionals. It wouldn't require a lot of professional training. So structured and focusing very, very directly on motivational interviewing. We did find, we used Marion's FIMP measure. We revised it and created a coach that fit our model and found that individual differences in coach ratings predicted individual differences in parents' change of positive parenting. So our intervention effects were completely mediated by the fidelity of the therapist adherence. Well, that makes it complicated because you can't just expect effects. You need to have an effective therapist. And as we look and train on this, I can see that many of our therapists who may not have formal training are quite skilled at working with parents, and I think we probably all agree that that's a universal for these types of interventions. So we're looking at first doing the handshake, then doing the training, fidelity, coaching, monitoring, and then certification, sustainability, and independence. So I'm just going to go real quickly through some trials that we have, then I'll tell you about lessons learned as we're going along. So right away, the big lesson was that we needed to trim this intervention down big time to be used in the real world. We needed to create half-hour assessments. We created a web-based support. We have a video portal where, and this is a big technological barrier, when therapists videotape their sessions, they upload it immediately and it goes on our portal. And it's confidential. It's more confidential than having videotapes hanging around. And then translation, I'd say cultural translation to Spanish. All of our work has been translated. And so our first, we were fortunate, I was very happy actually when McV opened it up to other home visiting programs because we got a little piece of the action. We're little guys in the whole game. We had one state that expressed interest for some reason in the family checkup. And so they're working with us. And lessons learned, okay, first of all, early childhood home visiting, highly underfunded. Most of the staff are getting about $20,000 to $30,000 a year. They have high caseloads. I'd say when we do our trainings, half of them are close to depressed because they have high caseloads. They're working on trying to prevent abuse, and they have no time for clinical supervision, and the supervisors themselves are stressed because they're trying to piece together funding structures. So I'd say the big barriers and liabilities are funding and time allocation for the developer ourselves. That was a huge liability. And then for the providers, time allocation, turnover, salary. So we trained some folks up in the family checkup, and guess what happens? Their first opportunity, they get a better job because they've got some training in evidence-based practice. So lose this job that's $25,000 a year and pick up one that's $35,000 a year. Why not? I mean, there's the incentive. Supervisors, really stressed, time allocation. Most supervisors are not paid to look at videotapes or meet with a group to go over clinical process. Most of those supervision sessions are about billing. How do I get funds this week? And then agencies. The agency heads are working super hard to try to get funding and getting, when you have conversations with them, they know so much about the funding structures and I know so little. So now pediatrics, we've done the same thing with pediatrics, and proactive screening is extremely important in a pediatric setting. Physicians are incredibly busy. They're not going to do extra work that they're not getting billed for. Even having them show up to meetings regarding planning an intervention is challenging because those aren't billable hours, and they're already super busy. So it's not a blame thing. It's just let's be realistic about their time and energy. So if we're going to be playing in pediatrics, we need to, I was really happy to hear about the pediatric screening measure. We need a brief screening measure that triages the families that need more support, reduced assessment and translation. So some of the barriers are the same. You're going to see similar barriers in each setting. Pediatric, the time allocation, I put an asterisk for providers. Who's the niche in pediatrics for this service? The closest I can identify in Phoenix Children is their social work. Nursing would be another good niche, but we don't really have a clear niche. And if you don't have a niche, it's not going to fly because people need to have a billing structure for it, and it has to be worked out well in advance. And then the supervisors, pediatricians are extremely busy, as I mentioned, and then funding and billing. So if we can solve the issue of billing, I think pediatrics is a fantastic setting. Affordable Care Act is a great thing, so the future looks bright. Finally, I'm running out of time. Sorry for that. I'm not usually a fast talker. The school setting, which has been by far the most interesting, we have the most experience. We've randomized 42 schools to our intervention, and we've worked, we started that project in 2008 when the recession hit, and so we were devastated by the lack of resources in the Oregon schools for doing this model. So at the same time they were losing funding, they were also implementing. And I have to say that I just have nothing but respect. And so we're now implementing in Oregon, about 25 schools. They're sustaining, and then we have 3 states that we're working with. Kevin Moore is doing a lot of the work on that. And now the experiment that's been really fascinating is with the Sweden schools. There's been about 5 or 6 schools in Sweden, and I have to say from 0 to 60, we've had maybe 1 training workshop and some follow-up, and I went out there about in November, and all of those providers get high coach fidelity ratings, and the supervisors are able to coach themselves. They've really uptake the model very quickly, and I attribute that to a high level of training in the supervisors. Most of the time when I do trainings there, they've all had exposure to many of our programs, Incredible Years, Triple P, Functional Family Therapy, all of them. They've exposed to a lot of the evidence-based practices. So quickly, what we've come to now is a strategy I'm calling systemic concatenation. I want to get that out there just because I like to say it. It's basically, at some point I see ourselves losing the program-esque part of the family checkup and having what we do embedded into an existing service. And so I look around and I found positive behavior intervention support is a great system for that kind of integration. So we've tried to integrate with PBIS, and that's our 42 school trial. And we've had many successes for several schools and some failures. I would say the biggest issue in the public school domain is the same thing we're talking about, time allocation. So a school adopts a program like this and then the principal leaves. We have turnover like every 2 years. So they leave, and then who's the champion of your program at the school level? So that's been a big issue. When you do have it, schools are an excellent setting, and I think there's lots to be learned from the school setting. So this is kind of a collective message that I'm hearing. Time allocation, readiness, salary support, professional niche, these are all factors that are probably going to lead to increased effect sizes. Some summary comments, many of these comments I've made already. I think that we need to think through the resources to the host agencies for adopting evidence-based practice and create incentives for the host agencies and for the leaders that are championing these programs. And I'm not sure what that means. It's a great discussion to have, but I don't see how it's going to work unless those folks are getting the same kind of benefits as the program developers, whatever benefits we get besides a lot of extra work. Not a lot of money, that's for sure. Educational support and training. So we just created a REACH Institute at ASU, and the goal is to get these programs out there primarily through low-cost training services, online training support, and online service infrastructures, really trying to reduce the upfront expense for agencies to get engaged, following Rob Horner's lead a bit. And the idea is that you want folks to engage with the service, and then fidelity will follow. If we have fidelity hitting, if we hit them hard on fidelity right away, we may lose a lot of agencies. We have a couple agencies within a mile of ASU. They might play, but they don't have the money for even initial training. So if that's a barrier, then it's ridiculous because we can't really connect with our own, neighbors because they don't have the funds to pay for some of these services. And with that, I should stop, and thank you for your attention.